Oh, no worries.
Yeah, I need to leave early. Nice. Yeah, that way I don't have to like
All right. Good morning, everyone. Good morning and welcome to today's special event, Consumer Preferences, Hospital Choices, and Demand-Side Incentives. I'm David Seltz. I'm the Executive Director of the Health Policy Commission, and I am so pleased to have everyone here today for what we hope will be a very informative and engaging conversation into some new research around what consumers value and prioritize in making their healthcare decisions. We're pleased to have so many members of the public here today. Thank you for being with us on this gorgeous first day of summer in April. We hope to conclude our agenda promptly on time, and if you want to grab lunch out in the common, I highly recommend it after today's event. We're very pleased to have a number of distinguished guests with us today. First, I want to recognize members of the Health Policy Commission Board, starting with our Secretary of Health and Human Services, Secretary Mary Lou Sutters. Thank you for being here. Also have Commissioner Don Berwick, Commissioner Tim Foley, Warren Peters, representative of Secretary LaHorry. Thank you all for being here and supporting this work today. I also want to recognize a member of our esteemed General Court, Representative Randy Hunt. Thank you for being here as well today. Rick Ward is being pointed out to me as well, one of our esteemed commissioners. He is also going to be playing a little bit of an official role later in the evening, later in the agenda, so I'll introduce him at that time. I also want to recognize many members of the HBC Advisory Council. You are too many to call out individually, but you know who you are. Thank you for participating in today's event. So with those distinguished guests, just a quick round of applause and thank you for being here today. It is now my privilege and honor to introduce to the podium the chair of the Health Policy Commission Board, esteemed healthcare economist, my boss and mentor, Dr. Stuart Altman. Thank you.
Thank you, David. So what I'd like to do in just a minute or two is to put this whole discussion into a little bit of a broader context. I think we all know very well that in 2012, the governor first suggested and the legislature passed and signed Section 224. And this state, this Commonwealth, embarked on a unique experiment within the United States to see if it could control the growth in healthcare spending so that we could have the Commonwealth healthcare spending grow in line with our income. As someone who has spent a fair amount of time around the United States, I can tell you how much the rest of the country, if not the world, is watching us to see if we can pull it off. And the reason why it's such an interesting experiment is that not only did the state, for the first time of any state in this country, commit total spending, not just Medicaid spending, to grow, to be somewhat under the responsibility of the state, but to do it in a way without regulating prices, and to do it in a way that allowed much of the market to continue to function. So in doing that, it created our little group, the Health Policy Commission, to monitor what's going on and to try to encourage, cajole, suggest changes in the healthcare system so that we could live within the benchmark that was established. Now, to do that, every once in a while we've made a little news and a little excitement as some big mergers have occurred, and we occasionally suggest that maybe they're not necessarily in the best interest of the whole Commonwealth. And sometimes the Attorney General and the courts have listened to us. But you know, that is a pretty blunt instrument. The ideal for us, and I would think for most of the state, is to never have these mergers occur if they don't need to occur. So, in the end of this week, I am going to be giving a talk in New York to a large group of health economists from around the United States, which are looking at activities around mergers and acquisitions. And this is the title of the talk that I'm going to give, which really is the basis for the discussion today. And the title is, you can read it up here, Can we prevent forced health system marriages from taking place rather than trying to stop them appearing? And of course, I'm going to talk about what's going on here in Massachusetts. The essence of what you're going to hear today is whether we can figure out a way to sort of develop an appropriate balanced delivery system. I'm talking about a balanced delivery system. This is not an attack on our academic medical centers. I'm a long-time supporter of our academic medical centers, but they have a role, but so do our community delivery systems. And what we're going to be looking at today is how do we understand why it is that Massachusetts by far leads the country in the use of our academic medical centers for fairly routine and services that can just as easily be provided in the community and at substantially lower cost. That's what it's all about. And that's why I picked this title. What I see here and around the country is that several, if not significant numbers of community hospitals that do not want to merge are being forced to go to merge because the alternative is bankruptcy and no longer functioning as a unit. So what we're going to be talking about is understanding the internal dynamics of why patients choose to go to some facilities rather than others, and what could possibly be done to prevent it. Again, this is not an attack on our academic centers, but it is a view to positively bring about a better balanced delivery system so that we can live under the benchmark that we've established under Section 224. And with that little introduction, I'm going to turn the program back to our great executive director, who will then introduce the speakers and the panel in the forthcoming. So thank you very much, and I look forward to a good discussion. David?
Thank you, Dr. Altman. Just to walk everyone through today's agenda, I hope you grabbed your program book on your way in. That contains the full agenda, as well as full bios of all of our researchers, presenters, and panelists. First, you're going to hear a presentation on new HPC work conducted by the Health Policy Commission in conjunction with Tufts University School of Medicine. Leading this presentation is Dr. David Auerbach, the HPC's Director of Research, who will be joined by our lead academic collaborator on this project, Dr. Amy Lishko, who is an associate professor in the Department of Public Health and Community Medicine at Tufts University. Want to highlight that we are grateful for the financial support of the Robert Wood Johnson Foundation, who made this research possible through a competitive grant opportunity. This work builds off of previous work by the Health Policy Commission, including our cost trends reports and the community hospitals at a crossroads report, which we released last year. That crossroads report, some of which exhibits you'll see around the room today, highlighted the vital role of community hospitals in the Massachusetts healthcare system, but also discussed the challenges they face, including the increasing proportion of routine care that is being delivered by our higher cost teaching and academic medical centers. This trend is, in part, driven by consumer preferences and perceptions of value. Through this new work, we sought to engage consumers directly and deepen our collective understanding of how healthcare decisions are made and considered every day here in the Commonwealth, and to whom do consumers turn to understand cost and quality issues. As you'll hear, it is clear there is an opportunity to greater empower consumers with cost and quality information in order to increase their use of high quality, effective, community-based healthcare settings. Our second presentation this morning will be led by Dr. Anna Sinayako, a research scientist at the Department of Health Policy and Management at the Harvard School of Public Health. We've invited her to participate today because the focus of her extensive academic research is to understand consumer decision-making in healthcare settings. Today, she'll present on how innovative health insurance benefit design, namely tiered and limited network products, can succeed in incentivizing value-based decisions and ultimately save the system money. Following the research presentations, we'll bring forward a reactor panel comprising a range of stakeholders and to discuss how we can turn research into action. We hope to engage you in the audience in that conversation as well, and we'll provide an opportunity for an audience conversation with the reactor panel and the academic presenters. So with that, I will turn it over to our first presenter of the day, Dr. David Auerbach.
Okay, thanks, David. Okay, so I'll give a really brief summary of the background, and then I'm going to take a step back and do a deeper dive into some of the context that David mentioned just now. So as a lead up to this study, the HPC has consistently found that community hospitals provide care of similar quality but lower cost compared to teaching hospitals. And a lot of this results was presented in the community hospital at a crossroads report that we released last year. This is especially a problem. It's an issue in Massachusetts here compared to the rest of the country. In terms of our Medicare discharges, we are more than twice as likely to use teaching hospitals compared to the rest of the country. 42% of our Medicare inpatient discharges took place at a teaching hospital, compared to 17% at the rest of the country. So higher prices, same quality, we use them twice as much. Massachusetts has done a number of things to try to address this, try to steer patients towards higher value settings. Demand side incentives we'll be talking about mostly today. Things like tiered and limited network products. Also incentives on the supply side for providers, for physicians. A lot of these are alternative payment models. We'll talk about those a little bit today also. But this is mostly focused on the demand side. And yet, even with all of these efforts, these trends have pretty much stayed the same, or in some cases gotten worse. And I'll show you that in a minute. So leading up to this study, we're trying to understand why. We're doing all these things. They don't seem to be moving the needle. What could we do? And what would we take? So going back, this chart is showing the average cost of a discharge at an academic medical center, a teaching hospital, or community hospitals in those four boxes. And you can see those price differences, a couple of thousand for a given discharge. And there's a lot of variation on the community hospital side, but on average, those prices are lower. You can see on the bottom, we looked at a number of quality metrics, and here is just one displayed, readmission rates. And in the case of readmission rates, you see that actually the higher the cost, the higher the readmission rate. You would hope that it would go the other way, but that's one example of no relationship between quality and price, from what we can tell. And when you drill down to very specific conditions, procedures that are standardized and kind of common, such as hip replacement or knee replacement, you see the same trends, the same outcomes, the same differences in quality that really are not systematically any different. You see the same kinds of price differences. Also, this study addresses not just one group of hospitals with another, but whether you're getting care at a hospital or in a community setting for standardized procedures such as MRIs or colonoscopies. You see price differences, and yet at the same time, a lot of patients continue to have these services met at the hospitals. So we have these price differences. It wouldn't be as much of a problem if most of the volume took place at the lower priced places. And that is not what happens, it's the opposite. So on the left, you can see the distribution of hospitals according to their price. In that top band in the dark blue, about a quarter of hospitals have prices that are more than 20% above the average. In the middle band, in fact, it is those hospitals that receive about half of the volume of care. So most of the care is going to the places with the higher prices. And in the third band, of course, it follows that most of the revenue is going to those high-priced hospitals. And where is that volume coming from? This is part of the problem as well, that a lot of the patient care delivered at these AMCs, and here are the Boston AMCs. The top band in green shows that it's coming from other regions, and it's community-appropriate care. Low acuity care, routine discharges that could be handled at a community hospital when people travel to Boston. And this slide shows that what is the average cost when someone does that, when someone travels to Boston from another part of the state for a routine care that could be done in their home region. That's the average cost depending on where they started from. $3,000, $4,000, $5,000 additional spending for those individual pieces. And that phenomenon of traveling to Boston for routine care has grown over time. Here is just one example of delivery. You can see that in 1992, about 3/4 of births happened in community hospitals. And by 2012, it was half and half. And this graph is showing that extent of the migration from, depending on where people started from. It's pretty large in some regions. And so here, now we're stepping back to all community appropriate care, where we've defined as care that could be, again, could be treated in a community hospital. What proportion of that care was actually treated at community hospitals? Going back to 2011, it was about 55%. And over the years, it's gone down and down and down. Now it's about 53%. So slightly decreasing. Again, despite the efforts that we've been making on the demand side, on the supply side, and on incentives, some would say it's going in the wrong direction. A few months ago, the HPC did something of a thought experiment where we imagined, what if we could reverse that trend? What if some portion of that care shifted back to the community hospitals? How much would it actually save the state? If we shifted 5% of that care back, so that we got to about where we were in 2011, that would be a savings of about $43 million statewide per year. And of course, if you could shift more of that care, 10% back to the community hospitals, you'd save about $86 million. There's a big opportunity there. Okay. So, what's going on? Why is this happening? That was the motivation for the study. We applied for a grant from the Barbara Woodhouse Foundation in 2015, and we received that award. And I would acknowledge that having helped to manage that grant. And the study had 3 parts. I'm going to talk through the first 2 parts, and then I'm going to hand it off to Amy, who's going to talk through the 3rd part. The first part was a survey. It was a specific kind of survey called the Discrete Choice Experiment, and I'll explain that on the next slide. But this is where we asked 1,000 Massachusetts residents, what are your preferences? We gave them scenarios and made them choose. And then we learned from them what mattered to them, why they chose what they chose. We also analyzed claims data, the Massachusetts All-Payer Claims Database, to look at, okay, people told us what they would do in hypothetical situations. We wanted to see if that sort of matched what people actually did with the choices they did make. And then we held a number of focus groups to understand at a greater level of depth what they were telling us in the survey and what the data was telling us. So here's the details of the survey and how that worked. 1,000 mass adults. Here we were focusing on more of the commercially insured population. Those are the ones who face these differentials in prices. We chose 4 conditions or procedures. We wanted to think about the kinds of conditions where people would be making an active choice that you can plan in advance. But we also wanted a range of complexity or acuity to test how people responded in different scenarios. So we're looking at an MRI scenario, a maternity, a simple delivery of a baby, knee replacement surgery, and treatment for colon cancer and chemotherapy. Those are the scenarios that will be shown. And we tested a number of things, but the main features that we highlight here, we asked them about out-of-pocket cost, referral from a physician, or a PCP, quality rating of the different choices that they might be making. And in the MRI case specifically, instead of quality, we asked about convenience. We gave them scenarios where could have your MRI in a hospital or in a freestanding center that was open throughout the day. Okay. There were a number of other questions we asked in the survey for context, and we'll be showing some of those also coming up. Here's what what's called the discrete choice scenario looked like to someone taking the survey. I gave them the scenario. This is the one for knee replacement. Told them a little bit about what it is. We said, here, okay, you could choose to have this at a community hospital near your home, or at an academic medical center, and we listed the names of all of them right there. They're probably familiar with them. And then we varied some of the different parameters in the screen below. We gave them a hospital quality rating, which we summed up at just the number of stars, 3 or 4 or 5. We noted that in some cases they would have a referral from their physician, in some cases they wouldn't. We gave them differences in out-of-pocket costs, and then made them choose. Okay, so that's the scenario, and I'll show you the results in a second. Before I show you the results, to understand what those results mean, this slide will help walk through how to interpret the numbers that I'm going to show. So imagine at the starting point, all of the parameters are the same for both hospitals, and we have some group of people who would choose the community hospital, maybe it's closer to their home. Some group of people would choose the AMC. And then, the way we interpret the results is we are able to change one factor at a time. In this scenario, in the bottom half, we're changing the out-of-pocket cost. And then we ask, all right, we just changed that thing, and we changed them all in favor of the community hospital, and then we ask what % of folks now switch their preference, switch their choice from getting care at the AMC to the community hospital. And I'll be showing you those percentage changes. In a sense, you can think of it as the % of patients who shift. You can also think of it as the loss of volume from the AMC if you were to change this one factor. Okay, so most of the results are on this slide. I'm going to walk through it slowly. First, we'll decide the MRI, but here's what these numbers mean. First, look at the blue bars, which are the scenario where there's $1,000 added copay for care at the AMC compared to, let's say, nothing for the community hospital. How many people shift if they now face that $1,000 differential? In the case of maternity care, it was almost 30%. We said, oh, $1,000 extra to go to the AMC. I'm now going to switch. I would prefer to deliver at the community hospital. That's a big number. In the knee replacement case, it's a bit less, about 20% would shift. In the case of cancer care, even a highly complex care like that, still about 10-15% would shift with $1,000 copay. Okay. The orange bars are showing the results for referral from a PCP. In the maternity case, almost 50% would switch to the community hospital if their physician referred them there, or perhaps to an OB who delivered there. In the knee replacement scenario, about a third, very highly dependent on physician referral. The cancer care, there was an insignificant effect, that's why it's shaded that way. The final parameter, quality, here we're testing the effect of the patient was told you have the community hospital has a 4-star rating, the AMC is a 3-star rating. How much does that matter? It mattered fairly a lot, especially for the knee replacement in the cancer scenario. About 30 to 40% of people would shift given that differential in the quality rating. Okay. Now going back to the MRI case, it's a little different because there the copay was just $100, not $1,000. It was scaled to something that would be realistic in the market. Just $100 would shift half of the sample from a hospital-based MRI to a freestanding MRI. And the effects on referral and quality here, in this case it wasn't quality, but it was a convenience factor, also shifted a lot of people to seek the MRI in that community setting. Okay, so main takeaways from this slide, these are all big numbers. These are a lot of people who say that they would shift. Number 2, there's a pattern. We ordered these along the bottom in terms of the more high-risk things like the cancer care on the right, more routine things on the left, and you see that the blue bars go down. As you get more and more risky, you see the effective cost goes down. But at the same time, the effective quality goes up. This is something that we focus on in the focus groups, and Amy will talk to that, and that is supported by the qualitative data as well, and it makes sense. Okay, we then tested the cost parameter a little bit more. We wanted to see, well, what is the pattern of cost? How much money does it need to ship people to the community hospital? We tested a $750 copay, a $1,500, and a $4,000 price point. And you can see the pattern here is interesting. It's not a straight line. you see a big effect as you go from $750 to $1,500. And this is just for the knee replacement and maternity. And then it sort of flattens out after that. So that's kind of suggestive of you need a fair amount of cost to move people, and then eventually there's a diminishing return that starts to happen. Okay. That's the end of the survey results I'm going to show. And we looked at the all-payer claims database to try to get a sense of, do those results make sense? These are people responding to hypotheticals. Are they at all meshing with what we see in the real world? Here, the best example we could find in the claims data was maternity. And we narrowed down to delivery at just the Brigham and Women's Hospital and Mass General as our outcome. And wanted to see 18% of deliveries in this data set. What affects people's choice to go there? And some of the variables we had to look at in this claims data, they're not ideally what we would have wanted, but it was what was available in the claims. And for example, if somebody had a deductible or not, just the presence of a deductible, that shifted about 5% away from the Brigham and Women's or Mass General. So that's an effect of about 5 on a base of 18 points. It's roughly a third. Would shift away from the Brigham or Mass General for having a deductible. And those are kind of in the range of the $1,000 typically that we saw before. So that gave us confidence that, yeah, these results seem to be kind of in line with what the survey was telling us. Or being in an HMO or a coordinated care plan, similar effect of about a third of people seem to be affected by that package. Okay, now I'm going to hand off to Amy, who's going to talk about the focus group results.
Thanks, David. Good morning, everyone. So we conducted 8 focus groups in and around the Boston area. We didn't have any participants from Boston that were residents of Boston, so they were residents of the suburbs of Boston. They were held in Framingham, Braintree, and Woburn. And the point of doing the focus groups was really to add a little more texture to the responses that we received from the survey. We felt pretty bullish after we got those survey results and felt, wow, there's a lot of movement that can be made here. But we want to understand how people felt about these ideas, cost sharing and physician referral, and maybe understand a little bit more about if we were going to pull some of these levers, what were some of the communication strategies we'd have to implement in order to, how would we talk to consumers about these plans? So I'm going to talk mostly today. We gained a lot of information from the focus groups, but today we're going to focus mostly on the levers that David mentioned, the levers of quality information, cost sharing, and physician referral. So the first we'll look at is quality. How did consumers perceive quality? David showed you that we presented this really in a lump sum star rating. So we talked to patients about, or consumers about what they thought, was in that star rating. What kind of information did they believe was in there? We also asked them about the acceptability of this academic medical center versus a community center. And generally, people really felt that the community hospitals couldn't deliver on quality as much as the academic medical centers could. And they really thought about this in terms of how invasive the procedure was. But their idea of invasiveness was really broad. The examples, they struggled to give us examples of what they thought could be handled in a community hospital setting, which was a little bit dismaying. So here's some quotes that we heard from people that are just indicative of what they were going through. Stuff like a broken bone or something like tonsils, I guess, maybe something like that could be done at the local hospital, maybe a cyst or something. But I think something like cancer or heart surgery, you automatically think we should go to Boston to a bigger hospital. Another quote, if they had something big, God forbid, thankfully we're healthy, but if something big comes along, I want to be able to have their doctor that's affiliated with a Boston hospital. And in this case, they were referring to their child. So we tried to push and probe the consumers to give us, really some good examples and even sometimes pose those examples to them. And their idea of risk was really very broad, and they thought lots of things were risky. Even if they went to the hospital for something that wasn't risky, what if something happened when they were there that made it more risky? So it was very telling actually when we were having these conversations. The next was the idea of quality information. And who do they trust to provide them with this quality information? Because now consumers may be getting this quality information from their health plan or from their employer through their health plan. And generally we found, and the literature supports this as well, that consumers really don't trust information from their insurance companies or their employers, particularly when they feel like they're steering them to lower cost providers. They don't really trust that information. This slide here shows that most people really trust their doctor and their friends and their relatives when it comes to quality information. And they don't really trust the health plan or their employer or even some more what you would think of as unbiased sources such as government websites or newspapers and other websites. They really don't, according to the survey results, they don't really trust that information. When we asked them what they thought was in those stars, it generally fell along the framework that we all think about quality as being structure, things like the hospital's facilities, the training of the doctors, the ability for them to have the high technology machines. But they focused really a lot on structure. And I think people in the profession maybe have moved away from structure and more into process and outcomes. And I think the consumers, at least, were still really fixated a lot on that structure, on those structural variables. They were also concerned about process, but the process was a little different than how we think about process. The process was more about, how fast I can get in and see somebody, whether I can get a good diagnosis right away, or whether it takes a lot of testing to get to that diagnosis. So it's a little different when you think about how we think about process variables. And finally, outcome variables. They couldn't mention, they really didn't think too much about outcome. They had a little bit, maybe they didn't want to acquire an infection when they were in a hospital. They didn't want an error to occur, but they weren't really thinking too much about the outcome of their condition. Occasionally they would mention that, but it wasn't the primary focus of their mind. The next part of the discussion was around costs. And we presented to them some different types of plans, a narrow network plan and then two versions of a tiered plan. One which they were probably more familiar with, which is the kind of plans we have in place now, where you have the same premium, for example, you pay a premium, but then you pay a different price when you go to different facilities. And another where your premium varied based on who your PCP was, and then that PCP would steer you to providers. So we provided them with a typical benefit grid that outlined all these plans and had them spend a few minutes absorbing it and asking us questions about it, just to have them be familiar with the different plan types. And then we asked them questions about which plan they would choose and why they chose those plans. And through that discussion, we really determined that cost was important between the plans, but that also the provider was really more important than the cost. That cost mattered, but the cost would have to be really significant to have them move from one provider to another. Those tiers or the premium differentials really had to be significant. So here we have health care plans that limit provider choice are inherently unfair because high cost equals high quality. And that came out through, similar to what's in the literature, that people still equate high cost with high quality. Another consumer said whether you call it efficient or moderate or high, or if you call it tier 1, tier 2, tier 3, and here we were trying to understand how to present the different types of plans. It's really less or more. That's what people look at. It makes it difficult to decide. Do I want basic care or do I want the best care? So they were still making that connection that if they went with those lower cost providers or those lower cost plans, that was really going to be less care. And no matter how many times we said, no, the care is the same, but across those, the care is the same, it was something that people really couldn't absorb, at least not in a quick session with us. Finally, we were talking to them about the third level, the referral level. We really want to understand whether patients felt that, what that referral process was like, whether they felt like they could go outside their PCP advice and referral and choose their own physician, or how that referral process, how they perceived that in their health plan. For the most part, we found that people trust their PCP, particularly for routine conditions. When the conditions got a little bit more serious, some of the consumers mentioned that they would go and shop. But when it was for something routine, they would just follow their PCP's advice. Of course, people varied a little bit on that, in that if they really knew their PCP, they trusted that PCP more. If it was someone they were less familiar with, then maybe they would do a little more research. But in general, people felt that they would trust their PCP and their referral that they made. People weren't enthusiastic at all about physicians playing this role of steering patients to more cost-effective providers. They felt that the physicians shouldn't be thinking about the cost and that they really should just be steering them to the referral to the physician or the surgeon or the specialist that was going to know them and treat them in the best way. They also talked about for high risk kinds, for lower risk things, there was a stronger pull towards those more efficient providers, and they were less concerned about quality or physician referral. Here's a quote from one consumer: "I like having the choice. It's like I'll do the research myself depending on what it is. If it's something like my eyes, for example, I'm going to make sure that it's a reputable place and try to get some research on that doctor. If it's a physical, then I'm not too worried about that." So again, you can hear that sort of trend that almost everything is put into that high risk category. And it's only something like a physical where maybe it's not that risky. So from both the survey results and then also much more data than what I'm presenting here from the focus groups, we thought about some lessons that there might be for employers and insurers in trying to think about these demand side incentives for consumers. The first is that we really felt that you have to clearly present the trade-offs to employees and really clearly show the relationship between the narrow plans or the tiered plans, the networks, and premium costs, and really have people understand that there are trade-offs in all of the options presented to them. We got the sense that people didn't really understand those trade-offs and weren't really thinking about them in that way. We also felt that presenting side-by-side choices and really making clear the financial differences. People struggled with this in our sessions about what are the financial differences between these plans, and we're trying to calculate it on the spot. And we wondered whether, when they were at home trying to make these choices, did they spend more time with those choices? Were they able to make better calculations than they could just sitting with us for a short period of time? So really trying to be clear about those choices. The side-by-side benefit comparisons that I've seen are quite confusing, and I'm in this field, and I still find it difficult to make those choices. So I think trying to make that simple for consumers so they really understand those trade-offs would be one goal I think that would help. Focusing more on financial incentives and convenience for things that are more routine care. That came out really clear to us, that trying to do this for things like that consumers perceive as very stressful or risky is something that's probably not going to work. So trying to somehow use those incentives, such as convenience, for things that are more routine. But also at the same time, I think trying to shift that boundary, somehow educating consumers about what is risky and what isn't risky, and educating them is going to be really important. Because otherwise you're going to end up with just this, okay, for MRIs, we can send them somewhere, but everything else, they're going to go to the academic medical centers, which is not what we want to do. So somehow, slowly shifting that paradigm of what can be done well in a community hospital, and educating consumers about that. And some of the consumers we spoke to were more educated. For example, if they had had a good experience at a community hospital for a family member or themselves, they were advocating to the rest of the group when, even with significant pushback from the rest of the group, that no, you really can get that done at a community hospital. I had a great experience at a community hospital. So I think that it's not an impossible task, but it is a task that we have to do. We can't just assume people are gonna move to community hospitals when they have this preconceived notion that they have worse quality or that they can't do those things. So it's gonna take an education piece, I think, by insurers, employers, and all of us. Finally, aligning the physician referral incentives and providing information to support high value care. So this has to do more with thinking about how to use that physician leverage. Because clearly what we heard was that if the physician refers you to that community hospital, you're going to be more apt to go to that community hospital. And so how do we think about that in our paradigm here in Massachusetts? How do we think about how to shift that and how to use that that fact that we found from the focus groups to kind of shift care more to the community? Happy to answer questions when we get to that section of the discussion. But I'm going to turn it over to Anna to present her findings.
Thank you very much. I want to thank the Health Policy Commission for the invitation to be here today to share my work with you all. And I want to let you know I'm recovering a little bit from a cold virus, so apologize in advance for the hoarse voice. I hope you all can hear me. I'm here today to talk about my work on tiered network health plans. And tiered network health plans are it's a form of managed care provider network design. So what health plans do is evaluate providers. So it could be hospital, physician groups, or individual physicians are evaluated on quality and cost efficiency measures, and then sorted into tiers according to their performance. And enrollees in these plans are then not only informed about these providers' tier rankings, but also they pay different levels of out-of-pocket cost sharing depending on which physician or hospital they choose to go to. So if you choose a provider in the top performing tier, you pay as an enrollee or patient less out-of-pocket. That's the overarching design that we'll be talking about. Before I get into the work, I want to acknowledge a few important folks here. My co-authors, Mike Chernew and Mary Beth Landrum, on some of this work, and Matt Frank, who led a piece of the analysis. We're also grateful to funding from the Commonwealth Fund for this work. And finally, I'll be presenting findings based on the tiered network health plans offered by Blue Cross Blue Shield of Massachusetts today. And so I want to acknowledge Dana Saffron and her team for sharing data with us and answering questions along the way. So before we really get into it, what do we mean here by higher value care? What are we trying to do when we talk about steering consumers? And I think really basically it's the idea that higher value healthcare is care where we're paying more, we're getting more for it, or when there is equivalent quality, we are having our patients or consumers go to providers that are lower cost. And the reason that this is a good thing is because when patients or the demand side of a health insurance market operates this way, it gives hospitals and physicians an incentive to try to improve their quality or lower their costs. And this is sort of what makes the market work, so we're all better off. Of course, I think it's well established that healthcare consumers don't behave in this way. We heard a lot about some of the barriers preventing this behavior in the last talk, but I also want to highlight a couple others, which is that the way that patients are insured today largely makes them not very sensitive to price differences across providers. You know, if you're a patient, you often pay the same fixed copayment for an office visit for the same type of care, regardless of where you go. Or if you have a really high cost event, even if you're on a high deductible plan, if you're going to exceed your deductible no matter where you go, again, that marginal difference in cost, that extra amount of money that's paid to go to a high cost place, it doesn't come out of your pocket. And so these are features of health insurance that make patients less sensitive to price differences. I think another important barrier here is that meaningful differences in price and quality across hospitals and physicians is hard to observe. And there's been a lot of effort among policymakers and payers to change this, to report on quality and increasingly to report on price differences and even out-of-pocket price differences. But we still observe when we talk to patients, when we evaluate these programs, that a lot of patients really still don't know how to find quality data, don't know how to find price data, or when they see it, they still report that it's not as meaningful as it could be. So this all sort of creates a context in which having tools to try to steer patients to higher value providers could really make a difference. And that's where tiered networks come into play to some degree. And the other point, which we heard a little bit about already, is that there's really meaningful differences in costs across providers, across the country, but here in Massachusetts as well. In the last talk, we heard a lot about how across different types of hospitals there's price differences, and that's actually true even within types of hospitals here. So this is a graphic from the report from the Office of the Attorney General from 2015, and it shows you by type of hospital what are the price differences paid. And so I circled, that 66% there. So for one payer, Blue Cross Blue Shield, at academic medical centers, AMCs, the price of the highest priced hospital was 66% more than the price paid by the lowest priced hospital. And these changes, these are not really changing over time, these differences, and they persist across categories of hospitals. And I think the other point in the paragraph following this chart in the report is that across a variety of outcomes, a lot of the work has been done to show there really aren't meaningful differences of quality associated with these price differences. So what this suggests is there's a real opportunity to try to steer patients to lower cost facilities without sacrificing quality. So that leads to tiered network health plans. So as I mentioned at the beginning of the talk, these are plans where hospitals or physicians are evaluated on quality and efficiency scores. You see this vertical axis from 0 to 100%, take 100%. Top score, 100% on the test. And the better performing providers are then given a top tier ranking. It could be tier 1, it could be best. There's different words that are used to describe this. Often, tier 1 and tier 2 are the bigger tiered in a network, and the smallest tier is the worst performing providers. And then alongside that are different levels of out-of-pocket costs. That OOP stands for out-of-pocket costs associated with going to a provider in the top tier. And there is an effort to try to make this as simple as possible for patients when they're making a choice. So this is a depiction of what, since this study is based on Blue Cross Blue Shield, this is based on the Blue Cross Blue Shield information that's communicated to patients. You can see the way that they describe their tiered networks is that the best performing providers are sorted into the enhanced benefit tier. Standard is the middle, and then basic benefits is the worst performing providers. And you can see how the cost sharing goes up as the performance of the providers goes down. So there's really two signals going on here, trying to get some movement on two dimensions, both through the quality information and efficiency information, and also by the fact that you simply pay less when you choose a better ranked hospital or physician group. The prevalence of tiered network health plans across the country has been generally increasing over the last 10 years. A big jump up from the level in 2007. This chart shows some data from the Kaiser Family Foundation for employer-sponsored health insurance. It's bounced around a little bit, and we see a drop in this most recent year. It's hard to know if that's just a blip or if it's the start of a trend. But I think generally, most of the major commercial carriers in this country offer tiered network health plan products, and they're particularly prominent in some geographies. And here in Massachusetts, we see over the last few years dramatic increase in the number of lives enrolled in the health plan with the tiered network, up to 16% in the last year. So it begs the question of, what's the impact of this network design? Is it actually having an impact on the choices that patients are making about where they're getting their care, and ultimately, are we realizing these potential cost savings that we think are out there? So in some early work from about 6 years ago, I evaluated the Massachusetts Group Insurance Commission's tiering initiatives. Both GIC leadership and state regulation created the opportunity for tiered networks to come into all of their non-Medicare health plans, starting in 2008. And I evaluated the impact on patient choices in the first 2 years of this program, so really early days. This tiered network program tiered specialist physicians, office visits, with co-pays that differed by about $10, $10 to $50 depending across the plan. And we found evidence that when patients were choosing a doctor to see for the first time, they were more likely to go to a high-rated provider, so one in the top or average tier, and moving away from those worst tiered doctors. And it was a meaningful loss in market share among new patients for specialist physicians of about 12% of their new patients in a year. But we did not find in this study evidence that patients were moving away from physicians who they already established a care relationship with. And then most recently, with Blue Cross Blue Shield of Massachusetts, we were interested in the impact on hospital choices and the impact on overall medical spending. Blue Cross launched their tiered network plans also in mid-2008, and after a year or two, it started to have increasing enrollment in these plans, so that in 2012, about 30% of enrollees in plans with similar generosity of benefits where there was a tiered network option were in that tiered network plan. You always worry when you're doing this kind of research about, what leads someone to enroll in a tiered network plan or offer a tiered network plan, because, there might be features about folks that they know they'll save money, or they're already using these preferred providers, so let's go into these tiered network plans. And that, if you don't account for that in your research design, you can get the wrong answer, get a biased result, make these plans look like they're better than they are. And so we, essentially, you can't randomize people to being in a certain type of health plan or not. So to address that, we took a number of different empirical strategies at a very high level, described them here. But one of the things we did is we focused our analysis on firms that only switched everybody to a tiered network plan or didn't offer the tiered network plan. So it wasn't at the individual level where you had the choice of being in that type of plan or not. So to try to eliminate some of that self-selection problem. We did some matching and weighting of people who were both in and out of tiered network plans, looked at changes over time, which allow us to do two things. One, have people already enrolled in this product, and then have tier designations change. And so it's sort of a random change for them. Also, looking at trends before being in the tiered network plan, making sure spending trends were very similar. And then lastly, small groups are very unlikely to offer a choice of health plan. And so we also stratified our analysis by group size, looking only within small firms. They're feeling pretty good about the assumption that the health plan that we're looking at is the only choice that these employees have. So the hospital analysis, here's a chart showing you the different co-pays that people faced depending on which hospital they chose. On the left here, you have people enrolled in a tiered network plan. You can see they could save about $900 or almost $700 depending on which hospital they chose to go to, and compared to folks not in a tiered network where they paid the same cost sharing regardless of their hospital choice. It was also the case that while inpatient admissions, there was tiered cost sharing, emergency department visits were not subject to this tiered cost sharing, largely because the idea is that patients who are in an emergency don't have time to think about where they're going. You don't want to get in the way of that kind of care. So that was the basis of our analysis. We compared both these two groups, those in a tiered network and not in a tiered network. And then we also compared for folks in tiered network plans, their choice of hospital for inpatient use versus emergency department use. And those are the results I want to show you today, where we see that we saw about 7% volume shift away from the least preferred tiered hospitals when when those co-payments were, or co-insurance was tiered, as opposed to on the emergency department side, we did not see the same movement. The Blue Cross plans tiered more than just hospital inpatient admissions. They also tiered outpatient surgery, high-tech radiology, primary care physicians were tiered at the group level, and depending on your plan, some folks also faced different levels of high deductibles depending on their where they went for their care. So if you went to a non-preferred facility, you had a higher deductible to satisfy before your health plan kicked in. And we looked for this, for enrollees in these plans, whether there was any evidence of a reduction in overall medical spending. And I am happy to tell you that the full analysis of this research is going to be published in about 4 weeks in Healthcare. And so unfortunately, I can't share the specific numbers with you today. I'm happy to do that as soon as I can. But that we find evidence of a reduction in spending associated with enrollment in tiered network health plans. That's meaningful. So I apologize for the timing, and I look forward to discussing the details with you. Hopefully soon. So in sum, I think there's just a few policy implications to take away here, which is that tiered networks here in Massachusetts seem to have promised as a strategy to increase value. We see some movement on the choice of provider when we're looking at movement of individual patients, and evidence that they're associated with lower total medical spending. I think a point I really like to raise here is that these health plans might have appeal to patients because they still allow for choice of provider. If you want to go to a hospital or a provider or physician in the least tiered, the least preferred tier, you pay more out of pocket, but there's still coverage for services there, as opposed to limited network plans where often there's no coverage for out-of-network providers. And so the other thing is, what these plans are doing is essentially sharing the savings associated with going to higher value providers with patients. You know, you chose to go to a higher value place, you're going to pay less out of pocket. It's sort of a shared savings program. And I think that the important question going forward is that, the effects of any tiered network plan will depend on the details of the tiering, how are the tiers actually structured, what's the co-payment differences, and what's the market in which they're implemented. And so understanding that and thinking through those issues is going to be important as we think about how to leverage this kind of benefit design to achieve higher value. Thank you.
Thank you, Anna. Thank you for soldiering through. We'll get you some tea. Thank you to our academic researchers. As I think you could hear, there are some opportunities here. I think we heard from the first presentation that consumers are willing to shift and consider high-value settings of care along a number of different factors, whether that's a quality rating or a physician referral or cost and that out-of-pocket cost. But they need clear and understandable information in order to understand these trade-offs. Interestingly, we heard a skepticism around kind of physician steering, and I spoke actually with a physician about that issue earlier today, and she said that when her patients ask her, "Are you just trying to send me to a lower cost facility?" She says, "Are you just trying to save money?" And she says, "Yes, I'm trying to save your money." The consumers have, this, I hate this term, but they have skin in this game. And so how can we make sure that there's value being attached to that? And so thinking about getting the right type of information into the hands of consumers, thinking about how we can use health plan design to support value-based decision-making is going to be the next focus of our agenda here today. So with that, I'm going to ask Rick Lord to come up, and he's going to moderate our panel. Rick is on the Health Policy Commission board. I think everyone in this room knows who Rick is. He is the CEO and president of AIM, one of our biggest business groups here in Massachusetts. And I'm going to ask the rest of the panel to just come up and join us. join our academics here at the stage. The way we're going to do this is Rick's going to just moderate a couple of questions for our stakeholders here, and then we're going to pause and open it up to Q&A and encourage the audience both to ask questions of our stakeholders that we have here today with us, as well as the academics who will stay at on the panel here to answer any questions about the work that we've done. So with that, I'll turn it over to Rick.
So thank you, David, and thank you, researchers, for that really interesting those really interesting presentations that you made. We have 4 reactors here today. We have about a half an hour for the reactors to comment on what they heard this morning. And then, as David said, we're going to open up to the panel. So I'm going to ask the reactors to keep your comments, brief and succinct, so that we can hear from all of you on a number of things. So David said, when he was kind of summarizing what we just heard, is that we heard 2 things. There are opportunities to shift the location where care is delivered based on cost information, quality information, physician referrals. But we also heard about the challenges that we face in all of those. And so I'm going to ask each of the panelists to tell me in 2 or 3 minutes, from your perspective, what was kind of the key takeaway from the findings that you heard this morning? And we'll start with Mike Kelkever.
First of all, thank you to the Health Policy Commission for organizing a great event. This is a packed room, and it's really important that these type of events on the demand side, incentives and consumer preferences continue. I think that's part of the challenge that we have, is continuing to amplify the need for more of these product designs and patient-based decision-making in the area. I would say I have 2 initial reactions briefly. One is that clearly patients are asking for, without really understanding it, they're asking for better quality metrics, more sort of commonly useful quality metrics out there in the natural domain. They're not trusting anyone right now in terms of that information. There's really not clear metrics out there that people understand, and I think we all have more work to do in that area if we're going to get people to be motivated, not just based on cost, but also on quality. And I think that's for everyone to take on as a challenge. The second issue I would bring up, and it's in reaction to Anna's good work on the Blue Cross tiered network plans, is that tiered network designs can work. They have to be properly calibrated, and in particular, the copay differentials have to be meaningful for consumers to drive behavior. But there can be, particularly in contrast to narrow network plan designs, some real benefits to the community while still allowing choice in services.
Great, thanks, Michael. Bruno, key takeaway.
Yeah, thanks so much. I'll also echo. Can you hear me? Can you all hear me? Yeah. Thanks so much. I'll echo the comment about, this is a really terrific occasion, and I feel very lucky, frankly, and a direct consumer of this information for the Group Insurance Commission. And I would say first quickly that what we're seeing again and again is that we call them patients, members, citizens, are good shoppers. Americans are generally good shoppers, and given the right information, they will make choices and they will be sophisticated about it and apply information differentially across domains of services. So we need comparably sophisticated product design if we're going to influence their behavior. I have to say that the presentation validated an experience that I had not that long ago when we were rolling out this year's product changes at the Group Insurance Commission, where we heard again and again from members of the state, in fact, that they assumed that higher costs equals higher quality. And so there is a huge amount of resistance to overcome. So we certainly have a significant challenge. And then last but not least, I've been trying to get my own arms around how it is possible that the Group Insurance Commission, which has been really, this is not my doing, this is really about my predecessor and former leadership, has been way out in front with limited network products, tiered network products, and yet when we look at the distribution of care, it looks exactly like the distribution that was put up earlier, namely we see approximately utilization and well over half of our costs taking place at high-cost institutions. And I can reflect more on what I've learned today during the discussion. I look forward to that.
Great, thanks, Roberta. And I also want to talk about your comment about consumers still think high prices equal high quality, and what do we do about that? But let's hear from Steve Walsh from the community hospital perspective.
So it's, I think we know the problem, but it's counterintuitive, right? It's counterintuitive to think you're gonna get more for less. If I go to Consumer Reports, I look up snowblower, I go price high to low, I think the highest price is the best snowblower. The difference is no one else is paying 80% or 75% of that snowblower for me. So I don't look at as hard when it comes to my healthcare. So we have a physician incentive problem. That's the first issue, and we saw that. People listen to their quarterback. They listen to their physician. It's not a fight between academic medicine, community medicine, or community health centers. It's really a fight between a patient and their physician, and the patient being educated enough to say to the physician, no, those incentives aren't aligned for us. So the system has to encourage physicians to send folks to high quality, low cost settings. So it's counterintuitive. The other issue that we saw is brand, because people hear from their friends, right? We'll play a little interactive game. I say, where's the beef? What do you say? Wendy's. I say, the quicker picker-upper. You say, Bounty, right? I say, blank is on my side. You say, Nationwide, right? I say, great care close to home. Nobody says Harrington, right? But if I say, until every child is well, what do you say? Children's. And that's not a children's problem. It's a Harrington problem. It's we collectively have to brand folks to go to a place that they perceive to be lower quality because it's higher value. And it's our time. We get a shot at this right now, and we got to get together and come together and do it. We've lost 4 in the last 36 months, 4 community hospitals. And every time we lose one, they go to a higher total medical expense setting, and that drives the cost of care up, and that makes the secretary's job harder and everybody else that's trying to save a system that is tipping over harder. So we saw it again today in black and white or in color. This is the problem. We know the problem. Most times we don't know the problem. Now we've identified the problem. It's up to all of us to identify the solution, which is counterintuitive, which is what makes it so difficult to solve.
Thanks, Steve Walsh. Steve Carey from Polar Beverages has been in the tiered space for a while.
Several years. And we do go to Harrington Hospital and Polar Beverages, by the way. We have been in the tiered program for several years, and I have been a proponent for the tiered program. And I will continue to push the tiered program. But it is not a limited program at all. If you want to go to Mass General, if you want to go to Dana, you can go to Tufts, you can go to any hospital you want. It's all about educating your employee. Over the years, the biggest problem we've had is when we changed to the tiered product. And when we go from a PPO to a tiered product, our employees were like, oh my God, what are you doing to us? And that's the response you're going to get. But what we did, we had meetings, we had mandatory meetings for every single Polar employee. Almost 1,400 employees. We had meetings at night, Saturdays, Sundays, because the insurance, I'm going to say the Crowley family is very important. And also to the community hospitals. To what Steve had just said, losing some community hospitals, that is a huge concern, especially in Western Mass. We lost a few community hospitals out there where our employees had to go to a basic hospital. I just want to make one correction also. On the basic, it is not the worst. I hope you take that word out of your vocabulary. Just because it's in the basic category, it is not the worst. It might be expenses, it might be costs, it might be a teaching hospital, but it is not the worst. Our employees have the choice. Unfortunately, we've had the concern these last 3 to 4 weeks. We've had 3 people come up with 3 different types of cancer. 2 went to the local hospital and 1 went to Dana-Farber. They had the choice, and yes, if they went to a basic hospital, they have a higher deductible. But we have given them the choice. They are educated. We give them the fee structure in black and white. So I am a very proponent for the tiered program. It does work, but you have to educate your employees. You have to continuously get the emails out, get the information out. It's just not, here you go, thank you very much.
Thank you, Steve. And my next question, maybe we'll start with you. I was kind of concerned to see the data that showed that consumers, when they're looking for information, they really don't trust government, their employers, their health plans. They trust their physicians and their friends and relatives. So, Steve, it seems like you have addressed this problem in a meaningful way. You're the employer. You instituted this, and can you talk a little about that?
And to the points of not trusting your employer and communication, the insurance, we are probably different than compared to some of your other companies. We have a healthcare concierge services, which is just for the employees' medical concerns, doctors, hospitals, services, procedures. We have someone on board who has helped us get through this, and this person is on our payroll now, 10 hours a week, helping us steer employees for the services, new doctors, or how can you help me with this? And we always, yes, we tell them what the cost is, because yes, we have blue collar workers, we have manufacturing, we have office, we have all different types of level. So we have to be aware of their concerns and also their financial concerns. So yes, we are a little different. We have continued to push the educational process, but it's not perfect. Some people want the Cadillac, some people want the Mustang, but some people, when they're going for their health insurance, they pay more attention to the car than they do their health care. So it is a continuous educational part on the employees and the employer's position.
So Steve, maybe the whole concierge aspect of it made your employees think you were taking a little better care of them by providing that service. Mike, anybody? Roberta, Mike?
Yeah, I would say the role of the plan, for example, or the GIC in this area is really important as well. And we have a vibrant website. We have over 1 million hits to what we call our Find a Doctor tool, just based on these issues, where a consumer can, in a direct way for their plan design, find out how much particular service will cost them and what the quality is for that particular service across the state. I'm not sure everyone knows that they have that service. And so I think we collectively as a community need to do a better job of letting people know that these tools are out there for folks to use. And secondly, and I think it's really important, we have to make these tools accessible and portable for folks. So one of the things that we're most excited about is we're making these available on a mobile device now for the first time. And so you can find your doctor, you can do your cost estimation tool, you can do it all through your iPhone or Android, not playing favorites yet. And so I do think we're moving generationally into this area where people want to have information, they want to shop around on services. But again, they have to know it exists. I still think too few people know it exists.
Sure. Roberta?
I would say, and this is my first year at the Group Insurance Commission, I knew this existed before, but having seen it in action, I mean, we basically go through a massive campaign each year leading up to annual enrollment. And in addition to written materials, online materials, we don't have something that aggregates across our various health plans, but we certainly also refer folks to the respective health plans. And we have a virtual army in the 1,000 or so GIC coordinators across the state who help us roll out and answer day-to-day questions. One opportunity, I think, that is really critical. I don't know exactly how to solve it, but as I was listening, it really struck me. We talked a lot about care that could be delivered in a community setting, but we didn't go down a next level and say such as. I think if we could find a way to sort of first socialize the notion that there is care that could be safely delivered in the community, I think we need to go through some kind of step to get the clinical community on board. I know that's a challenge, but I think it would be hugely impactful if we were walking around with something closer to a common definition of what can be, quote, safely managed in a community setting.
Yeah, and Steve?
Yeah, thanks, Rick. So the problem is still, as good a job as Steve might do, as creative a plan as Roberta or Mike might offer, the differentials still aren't enough to really drive consumers. So they can differentiate a plan at about 14%. It takes about 30% to really drive consumers. That's real money in their pocket, and that's collectively something that could happen at the legislative level that would allow Mike to design a product where folks can go to the low-cost setting and truly be rewarded for it financially. That will move some folks. The other thing we have to do is, this is really hand-to-hand combat. I mean, we need to be going to Rotary clubs and Lions and Chamber of Commerce and doing a Gateway City tour to talk about the importance of that hospital to the community. The importance of Lawrence General to Lawrence, it's absolutely unmistakable. If you go there and you look at the number of jobs, how it drives the economy. Holyoke Medical Center, how it drives the whole community. You begin to look at those gateway cities, if you lose those community hospitals, it's not just a quality of life issue as it relates to healthcare. It's a quality of life issue as it relates to the entire local economy. They are the largest employer in any gateway city. So we need to get out and tell the story. If folks maybe don't trust some folks do trust their parents, some folks trust their doctor, some folks trust their hospital, some their elected official. But it's all of us working together to get through to the consumer to understand how important it is that they use it or lose it.
And that's a good segue to my next question. What we heard in the survey was that consumers might be willing to consider going to their community hospital for routine care, but then, what is routine care? It sounded like, physical is routine, and anything beyond that, they want to go to the teaching hospital. So how do we change that perception of what, and Marie talked a little about this, what appropriately can be delivered at a community hospital? Because it's really consumers deciding where they want to go. So, we're ready to start.
Well, like I said, I don't have a process to suggest at the moment, but I do think it's really critical to engage the clinical community in some fashion. I think it would be so powerful.
And you said political community?
The political community. So the Mass Hospital Association, Mass Medical Society, I think it would be really a huge contribution if we were able to come up with some shared community definition. And what's likely to happen, like so many other things that we've worked on together, is that there will be areas of agreement, areas of clear disagreement, and a gray zone. But even if we could identify those areas of agreement, I think that would be hugely helpful.
And I'll add, Rick, I think that step at the point of care is a really important one, right? Because now we've seen surveys and studies on this issue for a long time, and there's one redundant fact. It keeps coming back to people trust their doctor for care decisions. And we'd be butting our heads against reality if we were to create a system that only was around the outside of that, and that's sort of what we've done. And so we have to get meaningful information in the hands of doctors and allow them, or mandate, or try to drive them to having those discussions with their patients one-on-one. Is it difficult? Absolutely, but it's critical for us to really get this message through.
Steve,
Thanks, Rick. I mean, the question is what can't a community hospital do? It's not our job to answer that. I mean, trust me, if you show up at a hospital and that hospital, whatever it is, can't do what you need, they're going to refer you to the appropriate place every single time. No one is going to try to do more than they are capable of doing. So go to the hospital closest to home and think in your mind, your community hospital can do everything. And when you get there, they will assess. Unless you have an MD, let them assess. And if it is necessary, they will send you to one of the top 10 hospitals in the entire world to get the care that you need. But don't self-diagnose and then decide I'm going to drive past 4 high-value hospitals, take more time than necessary out of your day, clog up an emergency department in a place that you may not need to be, and pay more money. Don't do that. Go to the closest facility to you, right down the street from your house. Let them help you. If they can't, they will get you to the right location. I promise. They won't do any more than they can absolutely safely do at high value and high quality.
I'd also add just one other thing, which is that plans have a responsibility to continually evolve on these products, right? So we looked at study results from, 2013. The products that we're developing now for 2018 look in many cases much different than this in terms of even the differentials between product design. And I think it's imperative for plans to continue to innovate in this area, to continue to drive value-based decisions by their patients, by their members. If it's just a carryover year over year, I think it becomes static and folks lose that value proposition at a patient level. it has to be meaningful for them out of pocket. And on the flip side, there has to be forbearance, or at least some legislative acceptance, regulatory acceptance to the fact that at times those copays and deductibles are going to be quite high in order to drive the behavior that we want. And so I think we can't have it all. We can't be all things to all people. We have to drive the behavior.
Yeah, right, real quick.
Yeah, no, I would agree with that, and it feels like the best place to chime in about the data that Anna presented to us, which was at a time when the copay differentials of the Group Insurance Commission were relatively low. And what's happened since then is that the copay differentials on specialty visits have gone up to 30, 60, and 90. The jury's not out yet about the impact. And on the hospital side, Steve, you would have to know that it's more like 275, 500, and 1,500. Those are very real numbers. Last but not least, we've elected to morph, is probably the way I would put it, to a group-based model so we can get the PCP into the conversation and also make sure, and I think this is critically important, that whatever schema we come up with can actually be operationalized on the provider side.
And I'd like to talk a second about employers' interest in tiered network products. I think one of the slides Anna showed was that, there was an uptick a few years ago, but it's kind of flattened out. That's what our member surveys show as well. In fact, the take-up rate for high deductible plans has gone up as opposed to this leveling off. How do we make these products, if these are one of the tools that will help shift care to more appropriate settings, how do we make these more attractive to employers? Steve, Karen.
When we started, you have the option, am I on? Yeah. Okay. You have the option of designing your tiered program the way you want it. This year, we went self-funded this year for our health insurance. And we actually lowered some of our costs for our employees. Chiropractor. They were 50, they've gone down to 25. We've lowered some other costs for our employees also. It's all how the company can afford to do the tiered program. You can work with your insurance company, but ultimately, when you're sitting across the table with your Blue Cross Blue Shield, and we've been with them for a long time, we have made changes to our program, even when we were fully funded. I just feel the tiered program does work. The last 5 years, I would say 3 out of the 5 years, we've had no increase to our employee weekly premiums. 3 years out of the 5 years. This year, we went up. Family plan, we went up $2 a week. In the single plan, we went up $1 a week more. So we have, in one way or another, tried to control our costs. Has Polar taken on more of the expense? Yes, we're paying 75% of the premium for our employees. I don't know if that's good or bad out in the public, but I think we do a fairly decent job on that. A tiered program, you have to give it a chance. One thing I'm going to throw out there, no one's spoken about, is you have to have a decent broker. Your broker needs to understand the tiered program. They need to understand your needs as a company. If you have a broker that you see once a year, see you later. I would say see you later. We sit with our broker at least 2 or 3 times in a quarter. We're self-funded for prescription. We're self-funded for medical. We're self-funded for dental. We sit and go through and see what the trends are, what's happening, what's going on. Is it work? Yes. But when you're spending $10 million a year on health insurance, that's a lot of money. So again, I just feel the tiered program, it's a work in progress. You have to educate your employees. And just to Steve's point about the community hospitals, they're very important to us. We have had Harrington come into Polar and explain their services to us. And we have had our employees trend back to Harrington because they understand what the services are. And unfortunately, we have increased our Western Mass group by over 100 employees. And to Steve's point, we have lost 2 community hospitals out there to a bigger hospital, which is a very good hospital, but they're basic. So our employees, if they're single, have a $1,000 deductible and a $2,000 family dollar deductible. This is a concern because this is out of their control. So the situation is they drive into Worcester and they go to an enhanced hospital. They still have the choice, but again, to Steve's point, we need to really concentrate on the community hospitals.
So Roberta, then I'm gonna open it up to questions from the audience.
One small sort of practical piece of advice I would give to an employer that's considering it is to design the tiering based on where you're starting from. So just for example, if your members are currently paying $20 for a PCP visit, what you want to do is reinforce the opportunity to quote buy down or buy up. So you might then do a 10, 20, 30 or a 10, 20, 40. I think it's critically important to think about where you're starting from and adjust accordingly.
Great, thank you all. So we'll take some questions from the audience. Kelly has a mic. First one from Stuart.
So one of the, we just finished our Price Commission report, and one of the most troubling aspects of that report, and I want to refer to Mike, is that what we learned from Blue Cross is that roughly 50% of the so-called savings from tiered networks go away because certain hospitals and providers, even within a network facility, either at the emergency level or at one of the aspects where the patients have no choice, charge significantly more than the network price. 50% of the savings. So Mike and Blue Cross cannot create tiered network differentials at the level that correspond to what David and the other panelists, Amy and Anna, say, because of the fact that a few very, I would say, questionable behavior is going on in the emergency departments and with some anesthesiologists and radiologists where the patients have no choice. If we don't solve that problem, my view is, from what I'm hearing, Mike, you will never be able to create sufficient gaps so that the patients will have enough of it. And Anna, your research is going to be severely limited by the fact that Blue Cross is not. So Mike, I don't know if you're
So,
going to check.
sure, after 23 years of marriage, I learned how to say I agree. I agree, first of all. And I think there's a meaningful inflection point for us as a community. There are opportunities, I think, to address these issues. The Price Commission also endorsed unanimously a series of out-of-network default protections that I think are be really important for the community at large to provide this backstop or a prohibition on this type of behavior. A prohibition on balance billing the member directly, surprise billing notices to consumers so that they know when they go out of their network plan or seeing somebody who's not within their network. And lastly, a meaningful out-of-network default rate for those services that do get charged so that we're not getting 450, 500% of the Medicare rate, which we've seen in terms of some of these charges. It's a system cost. We have tended to protect the member from those charges generally. The larger concern that we have is that that's not sustainable. That's not sustainable for the system at large. And I think it really is, as Stuart said, a few bad apples. This is not a pervasive issue where the Massachusetts provider system is acting deleteriously. They're good actors here. We're lucky we live in Massachusetts. This is an outlier and we can solve it, but we're going to need regulation and legislation on this issue.
Steve Walsh.
Thanks. Just because Stuart brought up the Provider Price Commission, there were two things that come out of that I'll just mention very, very briefly that are the biggest threats to community hospitals. And it wasn't the topic of today, but I want to mention them. Just one is that there's a subsection of community hospitals that are paid less than they actually need to provide a service. So the more patients that come, the more money they lose. It's a significant problem. It was addressed by the Provider Price Commission. There are recommendations to address that. So even if we drive all the folks back that we talked about today, there's 10 to 15 community hospitals that can't survive at the current reimbursement rate that they're getting from payers. And the second threat to community hospitals and to academic medical centers, both. And I think that everyone is in agreement on this, and I know Lynn Nicholas is here from MHA, John Orrin from COVID, is limited service, ambulatory surgery centers, those that are not affiliated with hospitals, that cherry pick the last remaining commercial patients from hospitals and don't take care of poor people. When we started this effort in 2006 to get access and coverage, there were 12 of them. There's now 150 of them. And in that time, hospitals have closed. So that is a significant problem. Not that we shouldn't have access to limited service clinics, but They should take Medicare. They should treat everyone that walks through the door the same way hospitals do, and they should pay into the system to help all of us holistically. So because Stuart brought up, I just want to mention 2 other things from the commission that we found. Thank you.
Great. A lot of questions are here. Maybe John Hurst, Liz Spears.
Question really for Mike. I'm a big supporter of the tiered network, but if Blue Cross Blue Shield, particularly for small businesses, also offer a, as an opt-in, defined contribution type of option for certain employees, a limited network, real strict limited network, that would really give them savings, that consumer savings each and every month in the premiums, as opposed to, let's face it, a lot of folks don't see the savings in their deductibles until maybe once in every 5 years. Would that not move more consumer behavior, and with it, would it not move more high-end provider pricing on the other end?
So I think it's a well-timed question, John, because I think it's one of the examples of evolving innovations in product design over the years. Blue Cross will be in market. We're already in market with something called Select Blue, which is a limited network product design. And paired with the new federal law on HRAs, which really sort of authorized and sort of promoted the development of savings accounts for the purpose of saving for these products, I think you're going to see defined contribution plans begin to start to become more the flavor of the month in Massachusetts. I think it'll be a slow roll. I don't think it's going to happen immediately. There was a prediction that this was going to happen 3 years ago, that defined contribution was the thing, the flavor of the month, and it's really not that month yet. But I think you'll see it as an option, so stay tuned. Products get filed shortly.
Anybody else want to comment on that? Spears from Holyoke Medical Center.
I'm Stuart Satiris, I'm President and CEO of Holyoke Medical Center. Thank you for the presentation. I think anytime we look at how do we help move the consumer preference, I'm very encouraged. We did similar to what Polar did. We went through tiered network a couple years ago. We're self-funded, did a lot of that education. We've seen some movement. We've also worked very hard in our community to shift consumer preference, and it can be shifted. I mean, I've said oftentimes Holyoke is sort of a living experiment. We have shifted consumer preference. We have now 20% more discharges than we had in 2013. It's about 1,000 discharges of patients who have come back to Holyoke because we've educated, because we've walked the street and told people what we do. The problem, of course, we have, and I'm glad Steve pointed out, and I agree with Steve, that the most troubling thing of the price variance commission was actually the underpaid hospitals, is that we're not better off. We're actually worse off. We're trying, but we can't. So my question specifically, it seems all the questions are for Mike. But the question is for Mike, and the question is the following. We have now a recommendation from the Price Variance Commission. What, if anything, is Blue Cross, as a leader and as a huge insurer in the state, is going to do going forward in the next few months to help those 10, 15 hospitals? Will they stand with them to make this recommendation something meaningful for them and to help them stay in business? And if so, how?
Like,
Not
at the spot.
I agree. I agree.
I agree with you. Good job. Yeah, I agree. It sounds good right now. I would say that we were really excited is probably too strong a word, but we were proud to be part of that commission discussion. I think all along, Deb DeVoe on that commission really underscored the need to have a community-based discussion on this topic. There were ramifications for the community at large if, in fact, the hospitals underperform or continue to financially underperform and we lose them as a Commonwealth. I think that it's a harder question than just one payer in terms of payer policy. I think there's a broader discussion that we have to have as a sort of common wheel on the issues. One of the things I would say is that the value proposition, for example, from tiered network products gets lowered. If payers are beginning to pay the community hospitals more money, the tiering that's underscoring the differentials in terms of the structure of quality networks for the tiered products change. So I think it's a complicated decision, and in some ways it supports the discussion today, but in other ways it kind of has to be adopted in a much more holistic way, involving all other players in the marketplace. The other issue, which I think is important to keep in mind, is I think we want to make sure that the private payers and the commercial market, the customer base, doesn't bear the cost disproportionately from government funding. And so I think the government funding aspects, and this is something where my friend Lynn Nicholas in the crowd has given me the old nod up and down. I think government funding is an important part of this puzzle. And I can say that now that Secretary Sanders has gone.
Great. Mike, so thanks Barris for the question. I will say it is broader than just Mike, and Mike's been reasonable and good to deal with. Just to put it in perspective though, to bring every community hospital to 0.8% relative price, 0.80 is $20 million, 0.23% of the $9 billion commercial spend. So less than 1/4 To bring everyone to 0.85 is 0.63. So it's just over 1/2 of 1% of the $9 billion commercial spend. So if the payers decided to, and they can't get together and do this, but if they could get together and do it, they could do it in an afternoon with a rounding error. So that's all we're talking about to make sure we stabilize the community market.
Paul Haddis and Barbara.
So quickly say people are doing a good job of protecting their, coming about their interests, they're totally expected. The thing interestingly, just to comment about Stu's thing for a moment, I've been in touch with lawyers locally, and actually, we're thinking, should we try to encourage consumers when they go to hospitals, basically whether it's for ED or for inpatient, where their consent treatment that they're exercising into, that it's limited to network providers only. So would that be interesting? Yeah. So I want to get to some of the other panelists. So I'm going to ask a question about the quality data issue. The finding was shared that people, these consumers or employees, tend not to trust necessarily their insurance companies or employers. But, we're blessed in the state, and like organizations like MHQP, I noticed Barbara's here, where there are sort of independent nonprofits that, in theory, could deliver that kind of quality information for people. And those of you who are in that arena, what are your thoughts about that? We ought to sort of neutral third parties.
I think that actually, could someone from the Betsy Leaping Center mention that, because Chia is working on the new cost and quality website, which will add some great information, at least to start on a select number of conditions and metrics. Do you have anything to add?
Nothing, I can be right on this.
I know.
So it's a work in progress, and it's a real challenge how you deliver usable information to consumers. And one of the things we've learned, it's no great surprise, is that there have been other efforts nationally to do this, and I don't think any of them, anyone would say, have been a grand success. So we have the benefit, and Chia working was really Chia is taking the lead on this to build off of those earlier attempts and try to deliver something better. But it's only as good as, in many ways, as the data that can support it. So I think it's really important, and we can't. The information has to be good, usable information, and there is a commitment to do that. And so you'll see more of that in the months to come.
Yeah, I was just going to add that I think that it really is a work in progress, and I think it's so important to continue the effort, because when you work that we've done to talk, survey consumers, similar, is that the demand for this information is really there. People care tremendously, really want to know cost and quality, and I think that one of the interesting things that we could do is learn as we go how to make it better. And I'm encouraged by something said earlier, which is how do we get this information into the point of care and have it be part of the conversation. If tools are mobile, or if clinicians become accustomed to having it be part of their care delivery workflow, maybe it's not the doctor, maybe it's somebody else in the physician's office, but I think our efforts need to continue in this area to help give patients this kind of information to help inform their decisions, because they really, evidence suggests there's a really strong demand for it.
Right.
The only thing I was going to add is that there isn't one consumer. So, like, I think we have to do all these things. The challenge is that, I'm thinking about the group insurance commissions. There are just a huge range of consumers, and they tend to take in information in a variety of ways and from very different sources. So, we do have to do exactly what you described. That kind of thing tends to be most satisfying to sort of the cognoscenti, if I could put it that way. One of the things that I have found very intriguing that we've been talking about are a lot of health plans have these sort of smart shopper programs. And there have been some successful experiments, with large employers and unions in New Hampshire. And we would love very much to do something along those lines. I think there are a lot of informal channels, places people align with, congregate, trust, that we need to think about how to leverage.
Great, and there's one more question I'm gonna ask, turn to Barbara Anthony. Barbara, as many of you know, is the Director of Consumer Affairs for a long time, has been a huge proponent of transparency and providing consumers information. So, Barbara, your question.
Thank you very much, Brenda. I want to say a couple of positive things. Don't fall off your shoes. No. First, I want to commend Chairman Altman and also Director Phelps, the entire agency staff putting on what I think is one of the best programs. You always put on great programs, and I think today was particularly excellent. And all the panelists have done a tremendous job. Academic presentations, which was great. So for consumers, this is really a win-win day. But I also want to add another piece of positive information that we've heard from a number of people that, at least here in the hub of the universe, we all equate price with high quality or high quality with price. But we're not on the end of the earth for no reason. There's the rest of the country, as we all know, that goes to our west. And I just wanted to tell you about a study that was done, released last Thursday, by a think tank in New York called Public Agenda. It was funded by Robert Wood Johnson and also the New York State Health Foundation. This was a national survey of consumers. It dealt with price transparency questions. But one of the questions came up with the following answer. And this is a positive note. 70% of Americans say higher prices are not, that's N-O-T, a sign of better quality care. So that's a hopeful message that maybe, everything that takes place in the hub isn't necessarily reflective of the possibilities. Now I have a question.
When did you become an optimist?
Today, it's 70 degrees out. Thank you. But a question that we've all heard about referrals and this sort of thing, and involving the clinical community and the physicians, obviously. I mean, a question I have, or a comment in terms of the difficulty of this, is that, at least in this, I'm sorry it's anecdotal, but it's myself, relatives, and so on, your physician is part of a medical practice. When you ask for a referral or you need a referral to a specialist, usually, in my experience, that physician is going to refer you, even if you do not have a limited network plan, even if you can go anywhere you want, such as I can go, you still get referred to somebody within that physician group practice. They may be good, they may not be so good. The cost may be good, the cost may not be so good. But it's sort of automatic, and I've learned over the years, there's about a 50-50 chance the person you're being referred to really knows what they're doing. Otherwise, you have to go and find someone yourself. So that's kind of a big issue, even with mid-sized practices, because they have lots of specialties that cover a lot of bases. And people get referred without a lot of other information, or I don't even know if it's allowed. My plan doesn't prohibit it, but I don't know what the inner workings of a particular practice are that keep you in that practice. And that means the hospital, or hospitals sometimes too, that those physicians are on the staff of. So you don't have a lot of choice at Steve's hospitals, let's say, in some cases. So it's a comment, and it's also a question that's presenting a problem. So I don't want to be overly optimistic, Mike. Thank you.
Anybody going to react?
Well, that was on my sort of my short list before coming in enough issues to bring up is that we've got to be careful because we have sort of trends that are pushing different directions. There's a lot of emphasis now on moving toward group models of practice. They do show a lot of promise, but they also have some hazards. And one of the potential hazards is exactly what you described, that we need to somehow be sure that the incentives don't become perverse, that we don't get into a situation where what's happening is what's in the best interest of the member from the perspective of their plan, their benefits, what they have access to is what is being communicated. I think that's a really very astute point.
Steve Karen?
I just want to bring up the point, we have employees who are in basic doctors' hospitals, and they have their high copay. They can tell the doctor they want to go for their services to another hospital. They can tell that doctor, I'm sorry, this is my program. If you send me to this hospital, I have a $2,000 deductible. If you send me to this hospital, I have a $50 copay. This is what we have done to help our employees say, okay, if you send me here, the light goes on. This is going to cost me, maybe $2,000. I want to go here where it's going to cost me $50. And there's just one other point I want to bring up also. Out of network, at Polar, the first thing out of our employees' mouths were, what if I have an emergency? Do I have to go through the book to see if I'm going to have to pay deductible? No. If it is an emergency, they're in an ambulance, they're going to an emergency room, they are charged in the low-cost, high-quality rate. It is, if you're sick, you're in an emergency, you go. But if you know beforehand you're going to have specialty work and everything else, that is when you have to look at your rates, at the cost. But if you're in an emergency situation, you just go, and if you're admitted to that hospital, you're charged $250 for your services, even if it is in a basic hospital. We have taken the concern out of there, because that was huge. We went to a tiered program. Do I have to carry the book with me when I go through, if I'm in an ambulance or if I'm going to the emergency room? You do not. You do not. So we have put that protection in there for our employees.
Steve Walsh, last comment, I'm mindful of the time.
Thanks, Rick. So this is where the fee-for-service world is in direct conflict with the accountable care organization world. And I think that some of this stuff will work itself out. I think Mass Health is actually leading the way with the new Mass Health ACO program. But it doesn't matter about network. If that doctor is on the hook, and we started talking about physician incentives or primary care provider incentives, if they're on the hook financially, if that person goes to a higher cost provider when they're in network or not, they're going to chase them out of the office and tackle them and drag them to a lower cost provider because the money's coming directly out of their pocket. There's a few providers that are doing a really, really good job of this. One of them is Lowell General. They do a terrific job of keeping people in network. Their doctors will chase people down the street and make sure they don't get on the highway to head towards the city before they're allowing someone to go to a high-cost provider if it's a service that they can do. So some of this will correct, but it has to, the physicians have to have the same type of incentives as the consumer does for it to work. And right now, as Lynn always says, we're in two canoes, and we've got to get out of that and all get in the same boat.
So picturing those Lowell General Hospital, their physicians running down the highway chasing their patients. With that, unfortunately, we have to close. I'm mindful of the time, so we go to 1:15.
Please join me in thanking Rick and this thank you, everyone. I also just want to recognize Representative Carolyn Dykma, who's also joined us here today. Thank you for being here. Please take the long way home, walk through the common, grab a water, and have an excellent day. Thank you, everyone.